Hello, future nurses of America. I'm doing this recording so you can watch it over and over again if you don't understand any concepts. The lecture for today is going to be on substance abuse. And in the psychiatric realm, many patients have what we call dual diagnosis, a term that I want you to remember. Dual diagnosis is when you have an axis one, a psychiatric diagnosis, along with a substance abuse issue. And when we're speaking about addiction, addiction is a disease like cancer or high blood pressure, and we treat it accordingly. So I'm going to share my screen with you. And let me go back to the beginning. So substance abuse. And substance abuse affects everyone. Many people think, hey, it doesn't affect me, but in some realm it does. I'm sure everybody in this class can name at least one person, either in their immediate family or a friend, that has a substance abuse issue. I like to use the term issue. I don't like to use the term problem because problem has a negative connotation. So as you can tell from the slide, it affects individuals, families, communities. Everybody's affected, okay? We spend billions of dollars a year for programs to assist people with their addiction. Okay. Why should I start this from the beginning? Hold on. So the overview, we're gonna talk about abuse dependence, okay? Both substance and chemical dependence. And you can be addicted to, almost anything. We have sex addicts, we have coffee addicts, we have gambling addicts, okay? And there are support in place as far as collaboration in community groups that help people overcome or to assist them with their addiction, okay? So think about this when you drink coffee or you don't drink coffee, or there's something that you like, maybe candy or whatever, and you don't get that. I know a lot of people, for example, their mood changes when they're angry, they're hungry, and they're angry. But with substance use disorders, it's characterized by a change in behavior. Okay. For you coffee drinkers, when you don't get your coffee and you become irritated or angry, or when you start to get a headache or you get jittery when you don't have it, that's withdrawals, okay? And you'll see when you're in clinical, when you have the primary diagnosis, let's say of schizophrenia, then you either have a secondary diagnosis of substance abuse. You'll see it either as marijuana abuse, stimulant abuse, meth, which is a big one, or what you'll see is PSA, and PSA stands for poly substance abuse. It involves 3 or more of a substance on a regular use. So poly substance abuse. And when you're talking to your patients, you need to ask them, do they use any drugs? And a lot of times they'll say no, and then when we do a UDS, urine drug screen on them, it'll come back as positive, and you'll talk to your patient about this. Hey, Mr. Jones, I see that, in your urine we found some cocaine. And a lot of times they'll say, oh, I didn't think you meant that. So a lot of times with these patients, you have to go through each drug separately, okay? All types of addiction, depressants, stimulants, hallucinogens, inhalants, sex, eating, those can be all addictive substances. And the 3 most abused are alcohol, nicotine, and caffeine. Alcohol, nicotine, and caffeine. And people think alcohol is okay since it's legal if you're 21 and over in most states. But you can actually die withdrawing from alcohol, and we'll talk more about that. Another one that we should put up there as well is social media. A lot of people are addicted to social media. I swear you can't go into a restaurant without seeing, a little kid, maybe a few months old, 1, 2, 3 years old, and they're already on an iPad. I know when I go out with my friends, we all put our phones in the middle of the table. The first one that picks up their phone has to pay the check. Okay. And there are some restaurants that will say that they will give you 10% off if you stay off your phone. So again, the top three most abused substances are alcohol, nicotine, and caffeine. Okay. So the process of addiction, okay, process addictions are eating, compulsive gambling, compulsive sexual disorders, compulsive shopping or spending, and compulsive internet usage. You see, these are not substances, okay? These are processes, okay? And it's very important for those of you in class that have kids or you plan on breeding, to make sure that you limit your kids' social media use or their TV use. Because one thing that we're seeing is more and more kids are being diagnosed with diabetes and elevated BMI or obesity when they're younger and younger. The rule in my house is that if you want to play your Game Boy or watch TV for a half hour, you have to do 15 minutes of something else, whether it's reading, going out and walking, combination of both. But kids should not spend a lot of time on social media, on TV, electronics in general. So intoxication, in the next 4 slides, I want you to know these really well, okay? So with intoxication, it's when you're drinking or you're using a substance and your behavior changes, okay? And this is clinically significant maladaptive behavioral change. So some people will drink alcohol, become really angry, some become happy. People that use stimulants, a lot of times they'll be up, are extremely paranoid. And one thing with stimulants, especially methamphetamine, that can mimic signs of schizophrenia. You can start hearing things, you can start having paranoia, okay? And what are those types of symptoms? Anybody? Those are positive symptoms, okay? And these affect the central nervous system, okay? So intoxication is substance specific. And when I say substance specific, it depends, it's on the substance, whether it's marijuana, cocaine, opiates, alcohol. Withdrawal is when you stop using it or you use less than what you normally use, okay? And it can cause significant impairment. So when you're coming off of alcohol, you can have seizures and you can die. When you're coming off of opiates or methamphetamine, you might get physically sick, but you're not gonna die, okay? And remember, all these are not due to a medical condition, okay? So you have intoxication is the first one, withdrawal is the second one. Now abuse, okay, is when you're using more and more, leading to an increased impairment. And this is within the past 12 months. Now at your level, don't focus so much on the duration, but focus on what is happening, okay? So these people that are abusing it, they fail to fulfill their major roles, like they're not going to work, they're not going to school, they're not taking care of their kids. A lot of times they're using the money that they're spending on these substances to buy the substances, so they're not paying rent, they're not paying for clothes for their kids, etc. And the second bullet point, where the recurrent use in hazardous situations, maybe drinking and driving, okay? Maybe they're forklift operators and they're using it. Maybe they're nurses and they're taking care of patients and they're under the influence. And more nurses have their license taken away due to these types of impairments. Recurrent substances related to legal problems. So I work a few days a month in a prison, and I've had people that have committed multiple DUIs and they're in prison because they've been caught, or they've killed somebody while they're under the influence. And again, they continue to use despite all these problems. All they can think about is where they're going to get their next fix, okay? And this is both psychologically addicting and physically addicting, okay? And next one is dependence. You're dependent on this. You build up a tolerance. So you need more and more and more and more to get that same high or that same feeling. When you don't get enough of what you've been using, you can withdraw, okay? And then with the third bullet point, where it says has a need for more of the substance than that was intended, okay? And this is where you come to the risk of ODing, okay? Because Patients think they can handle maybe a gram and they're using a gram and a half because they have that feeling. So they shoot up and they die. Okay. And when I used to work in the emergency room straight out of school, I used to work the night shift, and we'd get people into the emergency room at 2 or 3 o'clock in the morning that were beat up in a park. And I'd often ask them, it's 2 or 3 o'clock in the morning, what are you doing in the park? And they'd say, taking a walk or whatever. But most of the time, they were out scoring drugs, drinking iced tea, no sugar. Okay. And people with dependence, again, they're not fulfilling their life's role. Okay. A lot of times they will only go to a party if that drug is there. If that drug is not there, they won't go. And it really interferes with their work in school. Okay. In my career at Trade Tech, I've identified 2 students in my class that did have substance abuse problems. And one of them didn't make it through the program. The other one took my recommendations, got into a program, and is doing well. Okay. And again, with dependence, they don't think about anything else about scoring the drugs. They continue to use the substance despite knowing what can happen. Okay. And it's sad when you see parents that have had their kids taken away and they're forced to go into a program, but they refuse to go. So when they refuse to go, what happens is that their kids stay in foster care or outside of their care. And it's sad for the children. And I've had many, many children tell me that their parents loves the drug more than they love them, which is sad. So a lot of things happen when you use these drugs. And initially, you can't tell a person that's on drugs versus somebody that's not. But over time, drugs will age you. You might want to go and do a Google search of pictures of people on methamphetamine. Okay. It ages really quick. But some of the effects can be peripheral neuropathy, okay, alcoholic myopathy, alcoholic cardiomyopathy. Okay, excuse my pronunciation. But especially with alcohol, alcohol is an astringent and it burns. It burns the body. Okay. And remember, alcohol is metabolized through the what organ? That would be the liver. And your liver is the cleaning house of your body. So if you're taking a lot of medications and you're drinking alcohol, that can do a lot of damage to the liver. Okay. Alcohol can lead to liver cirrhosis, ascites. Ascites is when your gut, you look like you're pregnant and you actually have to go in and have taps. Okay. Esophageal varices, these are little veins in your esophagus that when you're drinking, it burns the outer lining of the skin and your veins start to leak. The first sign of that is you might be throwing up some blood, you might be passing blood in your stool, but this is a medical emergency. And once you smell partially digested blood, you are never going to forget that. Okay. Leukopenia, thrombocytopenia. The last one on here is sexual dysfunction. And normally with sexual dysfunction, that's when people will start looking for treatment. That's when people will start looking for treatment. Okay. So the next 2 slides, these are from long-term use. And when you say long-term use, I can't tell you the exact time. But the next one is Wernicke's encephalopathy, brain. This is when you're talking to somebody, they'll have some confusion. Their eyes don't move, they're looking directly at you, or if they want to look over there, they need to turn their head. Okay. Diplopia, some ataxia. Somnolence, they're not quite asleep, but they're not awake. Stupor is in their movement. And the good thing about this symptoms are reversible. So they stop drinking, you give them some thiamine, and they can go back to normal. However, if this progresses, this can lead to Korsakoff psychosis. They'll have poor memory. They might meet you today, but tomorrow they might not remember you. They confabulate. Does anybody know what confabulation is? They make up stories. They might have a difficult time learning. However, these symptoms are irreversible. So once you get to this level, you're not coming back. They still use thiamine replacement, and a thiamine replacement can slow down the progression. Again, it can slow down the progression. Okay. So everybody has been intoxicated one time or another, or you've seen somebody that's been intoxicated. And people that are intoxicated, they're disinhibited. They can have some mood lability. So one minute they might be happy, the next moment they're sad, crying. They have impaired social and occupational functioning, so they're not doing their job, or they might act bizarre. And I've seen this with really quiet people. Once you put a few beers into them or some alcohol, they talk more. Slurred speech, they're uncoordinated, they're more likely to fall, unsteady gait, nystagmus, which is the movement of eyes, and they can have a flushed face. So with a blood alcohol of 400 to 700, most likely you're going to die. However, as I told you earlier, when I worked in the emergency room, and I used to always work weekends, people would come in and we saw all the nurses, there was about 15 of us, we used to put $20 in a hat, and whoever could guess the most blood alcohol levels right, BAL, we would win all of that money. I think I won 2 or 3 times. But I've spoken to people that have had blood alcohols of 500, and they're talking to me. So what does that tell you? That tells you they're long-term drinkers. If I had a blood alcohol of probably 300, I'd probably be dead because I'm a lightweight. Okay. So withdrawal normally starts within 4 to 12 hours after the last drink. That's why it's very important when you're in clinical, or when you become nurses and somebody has a diagnosis of alcohol dependence, you want to ask them when their last drink was. Okay, when their last drink was. Back in the day, long before a lot of you guys were born, in the med-surg units, they used to put beer on the trays. That way somebody wouldn't go through withdrawal. So withdrawal occurs within 4 to 12 hours. Okay. And this is when you become extremely anxious. You'll have some fine tremors. You might have some nausea and vomiting, extreme tachycardia. You might be sweating. And again, when you're coming off of alcohol, it needs to be managed else you can die. Okay. So the very first thing, like when you're dealing with somebody that is in withdrawal, you want to make sure their side rails are up. Okay. You want to protect them. Okay. And when somebody's going through withdrawal, this is not a time for teaching because they're not going to understand what you're telling them. Okay. So, again, so take home message within 4 to 12 hours. Does anybody know the medication that we use to prevent withdrawals or to assist if somebody's withdrawing? Think about it, because I've said this in orientation. That would be your benzos, and some of the benzos are Ativan, Klonopin. Okay. The one that we give a lot is Librium, because Librium is the half-life is long, so it stays in the system longer. People that are in full-blown withdrawal can have some transient hallucinations. A lot of times they have tactile hallucinations. They feel like bugs are crawling on them. And again, when you're talking to somebody that has hallucinations, you don't want to feed into their hallucinations, but you just want to reiterate that they are safe. DTs, these are delirium tremors. And you want to ask a patient that has history of alcohol, do you ever have DTs? And they're going to know what DTs are, okay? The onset can be within 24 to 72 hours after their last drink. So that's when you want to ask them again, when was your last drink? So you not only have to worry about the withdrawal, but you have to worry about DTs. And these people are diaphoretic, extremely tachycardic, extremely confused, and they'll have delusions. Again, you monitor this with benzos and probably a medication that's going to stop them from having a seizure. And one of the ones that you have learned is what? That is Depakote. And what is the therapeutic level of Depakote? That would be 50 to 100. And remember, Depakote is metabolized through where? That would be the liver, okay? So you want to make sure that the tests that are done on them are your complete metabolic panel, because the CMP is not only going to have all your electrolytes, but it's going to have your AST and ALT as well. And you want, and those are the liver enzymes, okay? And duration for DTs can be 2 to 3 days. So you really have to monitor these patients. So again, addiction is a chronic brain disease. And if you have a firstly real relative that's an addict, there's a possibility that you can be an addict. And in my career, I've seen it go two ways. Either a person falls into that familiar behavior and they drink, or they're so disgusted by what they've been raised in that they decide not to drink. And people that are raised by addicts, and from my clinical experience, I've seen them have to take over the family. And I have people that are in their teens right now that pay all the bills and everything at the house because their mom and dad can't even manage a checkbook, okay? So drinking or all drugs, okay, what happens is that it works on your reward system, which is in your midbrain. And what happens is it's like feeding it. And you feed it, it gets excited, you feed it more, it gets more excited. And you have that feeling, that good feeling, and that feeling comes when you drink the alcohol or ingest the drugs, and you feel happy or whatever feeling you're looking for. Okay, and you'll hear some patients that state that they drink or they use drugs to self-medicate. Okay, because unfortunately in our society, it's a lot more acceptable to be known as a drug addict than someone that has a mental illness. And again, what is that term that we use to describe somebody that has a mental illness along with a substance abuse issue? That would be dual diagnosis. Dual diagnosis. So the brain reward system, its substance cause the dopamine, which is neurotransmitter, the serotonin, GABA, and it causes these to like excite. And if they're supposed to be like this, but they get excited, there's dysregulation going on. And this is only short term. And again, this leads to addiction, denial, and impaired control. So you talk to people that have a substance abuse issue and they'll say, no, I only drink on weekends, or I only drink when I'm stressed, or I only drink when the baby cries. They are in denial, okay? And again, this euphoria that they feel is immediate, okay? And this is when they have the craving for it. Think about what you like. Have you ever walked by a bakery and you smell like fresh bread or chocolate chip cookies or something, and you get really excited? You want it. That's what the addict goes through. Okay. Now, this short-term euphoria, it's only short-term, and during this time, the patient does not think about the consequences. Okay. And again, what happens is they can be arrested multiple times, lose their house, lose their family, and they still continue to use, okay? They still continue to use. And it's sad because I've seen people lose everything, but again, they need to learn, and sometimes they will change their attitude when they hit rock bottom. And patients will tell you, oh, my rock bottom was this. Maybe when they were placed in jail, maybe when their child was taken away, maybe when they lost their job, okay? And again, continued use leads to tolerance, and this tolerance leads to increase in number of doses and the frequency, okay? And there's also reverse tolerance too, where your body can't handle it anymore, and maybe you're used to using a gram a day, you shoot up that gram, and you die because your body can't handle it anymore. When you have physical dependence and psychological dependence, it's hard to break, okay? And again, in my clinical judgment, the psychological dependence is a lot more harder to overcome than the physical dependence. And I've had patients and I've known people that have had years and years of sobriety, and your guest speaker will talk about her years of sobriety, but how she has relapsed, where she's gone back to the drug or how she's gone back to the alcohol. So again, dual diagnosis, 33% of individuals with a psychiatric illness such as schizophrenia, bipolar, they can develop an addiction. Okay, that is what dual diagnosis is. So opiates, think of your Norco, your heroin. Okay, opiates slow you down. So you're not going to see somebody under the influence of heroin jumping all over the place. It slows you down. So as the slide states, I could pause this for a second. I'm having a hard time doing this. What should I do? Hold on. Because my boss is calling me. Sorry if I'm wasting your time. Stop share. And where's recording? So I'm going to share my screen again. So opioid withdrawal can occur 8 to 12 hours after. So what question are you going to ask your patient? When's the last time they used? Okay. So when they're going through withdrawal, they'll be yawning, they'll have a runny nose. A lot of times they'll sneeze, they'll get goosebumps all over them. So when you guys take your state boards, they're not going to ask you specific questions like that, but they will ask questions what might you expect withdrawal. Okay. And again, coming off of opiates, you're not going to die. You become really sick. You can have a lot of gastrointestinal problems, dilated pupils, abdominal cramps. So you manage the symptoms. And the duration can be 7 to 10 days. That's why a lot of these programs, they have detox. So they'll get you through detox. And then what they'll do is they will, after detox, they might send you to a psychiatric unit, or they might just discharge you. Okay. And with opiates, your heroines and things like that, they have what's called methadone. And methadone is your doctor will prescribe you that. And so you don't use the heroin, and methadone will not, when you're on methadone, you won't withdraw from the heroin. And don't do what I did. Is I was working in a med surg unit for a little while, and I walked into this patient's room, and she was about 70. So I saw that she's on methadone, and I asked her, so when's the last time you used heroin? And she just looked at me like I had 4 heads. And methadone can be used as pain medication as well. Okay. So next substance is cocaine intoxication. Cocaine speeds you up, like opiates slow you down. Cocaine speeds you up. Okay. And people on cocaine, they're usually euphoric. They're very grandiose. And again, since this speeds you up, you have the tachycardia. You become paranoid because you're not sleeping. And you're not eating. Typically, people that use cocaine are on the skinnier side. And you'll see the Hollywood types that use cocaine for a weight loss, but it is a bad substance to use, because your heart, if it causes tachycardia, your heart can only beat so fast for a certain period of time. So it disrupts eating and sleeping, like I said. And what happens is, and I'm sure everybody in this class, since you're in nursing school, you felt this, that you're when you're not sleeping, you become extremely irritable as well. Okay. So withdrawal, anhedonia, which is a negative symptom of what? Psychosis or schizophrenia. You can have cravings, irritability, fatigue, extremely moody, and a lot of anxiety. Okay. That's why when somebody comes in to the clinic, or they come into the unit, we always do a urine drug screen, because when we talk about mood disorders, bipolar disorder, a lot of these same symptoms are what they express. So you want to make sure that they're not under the influence of cocaine before they're given a diagnosis of bipolar. Okay. So we use a CAGE assessment on someone that is an alcoholic. And these are questions that you ask. And I want you to ask these when you're at the puff. Okay. It's called a cage assessment. And it says, first question, have you attempted to cut back? Okay. Have you been annoyed by comments made about your drinking? Do you feel guilty? Or do you need an eye opener in the morning to start your day? Because a lot of patients that are addicted to alcohol, the very first thing when they wake up in the morning is that they want to take that drink. Okay. They want to take that drink. So if they score 2 or more out of this, they need to be referred. And the other 2 assessments on there is the MASS test, the Michigan Alcohol and Screening Test, and the Addiction Severity Index. You don't need to know that, but you do need to know the CAGE assessment. So when you're talking to somebody that is an alcoholic, you want to ask them, have there been blackouts? Have they had loss of consciousness, changes in bowel function, loss or gain, sleep problems, all of those questions on there. Okay. Blackouts is very concerning. As I explained to you, I spent a lot of time in the military, and a lot of soldiers, they're known to drink. And I've talked to some of my fellow soldiers, and they'll go out, and when they come home in the morning, they don't know where they've been. Okay. Or they drove home and they didn't realize that. That is really scary. That is really scary. Okay. So when you're doing your physical assessment, you want to ask these questions. Okay. So you want to take a personal family history. So patients, clients that have a positive family history of addiction, they're more likely to become addicts themselves. Okay. And you want to ask about each type of substance. Okay. You want to ask them when the compulsive behavior started, pattern and frequency. And under patterns and frequency, I've noticed a lot of times that they underreport it, okay, or they're in denial, or they justify their use. And what justification is they state, well, I use it because my boss is an idiot, or I use because my psych instructor is too mean to me, things of that nature. Okay. Age at onset is a big one, because my youngest client, he started using methamphetamine at the age of 8 years old, because he was being raised by a mother and dad who sold methamphetamine. Okay. And I try to focus on the positive too, where it says periods of abstinence, which means how long they haven't used. And I always say, like, in the last 2 years, what's been the longest time that you have stopped, you haven't used? And maybe they'll say 3 months, and I'll ask them, so how did you get to 3 months? Okay. And they'll say, well, I was in a program, or I surrounded myself with supportive people. Well, they need to get back to that. Okay. And never force anybody into recovery. I appreciate the patients that tell me, hey, I'm not ready to stop using. Okay. And I appreciate that, because I don't want to put somebody, into a detox or into a rehab if they're not ready. Okay. And again, date of last substance use. So again, you want to find this out, because you want to find out as far as when you might expect withdrawals. And you always want to talk to them about DTs, delirium tremors. And again, ask about each substance separately, because some patients will tell you, okay, I stopped using cocaine and I stopped using heroin, but I'm still using THC or marijuana. Okay. And what you're going to see in your careers a lot of time is that marijuana dumbs you down, and people think just because marijuana is legal that it's okay. It's not. Okay. So medication assessment, you want to ask about pain medications, because some people become addicted to pain medications. I've seen that a lot in my career. And you should not use pain medication for emotional stressors. Okay. In my practice, I don't prescribe a lot of benzos. And that is because benzos are very addicting. So if you have a patient that's on a medication, whether it be a pain medication or a benzo, and they're running out of medication early, or they're giving excuses. I lost my medication, someone stole it. Okay. Then you really have to question that. Okay. And again, pain medications should not be used for emotional pain. Okay. And if you mix pain medications with alcohol, it can cause CNS depression and a patient can die. And you want to ask about over-the-counter medications too, because OTCs can have alcohol in them. And why do you think you want to ask about the use of laxatives? Because opiates can cause constipation. So if they're using a lot of laxatives, that means they're using a lot of opiates. Okay. So again, when you're caring for somebody that's intoxicated, you focus on safety. This is not a time to be doing any teaching. You do the ABCs, airway, breathing, circulation. You want to make sure the patient knows where they're at. And again, you want to look at their nutritional balance, okay? Because if you're not healthy physically, then it's hard to be healthy psychologically, okay? Does everybody understand that? Okay. So if somebody's withdrawing, maintain safe environment. You want to keep low stimulants because if there's a lot going around, then they're going to be more excitable. This is the type of patient you probably don't want right by the nurse's station because there's a lot of commotion there, but you want to be able to evaluate the patient, okay? So you want to monitor symptoms of withdrawal, nausea, vomiting, tremors, sweats, okay? All the ones we discussed earlier, and medicate as needed, and most likely with Ativan or a benzo, along with Depakote or an anticonvulsant, okay? Delirium tremors, remember they can happen 24 to 72 hours after last drink. And again, you would administer the following medications: anticonvulsants, Depakote, Tegretol, benzos, and that's drug of choice, sedatives, vitamins, and thiamine. Okay. And in the emergency room, when somebody comes in under the influence of alcohol, we normally start what we call a banana bag, and that's D5 half, normal saline, along with multivitamins and thiamine. And remember those two disorders that you require thiamine replacement. Make sure you know those. And we call it a banana bag because when we hang it and we inject the multivitamin, it turns yellow. Okay. So you want to make sure that you monitor fluid balance, comfort measures. And again, a lot of patients just aren't under the influence of one drug. So you really need to make sure that you look at that UDS. And UDS stands for what? That would be urine drug screen. Okay. And stay with the patient, okay? Reassure them that things are going to be okay. If they're having hallucinations, again, don't play into the hallucinations, but let them know that they're safe, that they're in the environment, okay? And you want to let the patient know to let you know when they're feeling like they're going through withdrawal, not to hold back. And where it says the last bullet point, begin education about addiction and goal of abstinence, okay? This is not when they're going through withdrawal, okay? This is when they're done and they can have, they can focus on what you're saying. And if they're not ready, hopefully they'll tell you, okay? So again, rehab, interventions. You want to make sure that you help them detox from all mood altering substances, okay? Ask them directly, are they having signs or thoughts of wanting to harm themselves? Because a lot of people, when they're coming off of these substances, they'll endorse that they feel suicidal, okay? Monitor for seizure activity. What medications do we give? That would be your benzos and your anticonvulsants, your lorazepam, which is known as Ativan as well, maybe some Depakote, Tegretol. Okay. And administer meds for enhancing abstinence. And these are different medications, okay? So if they're suffering from depression and anxiety, maybe an SSRI. And can you name 2 SSRIs? Zoloft and Prozac. Medications for anxiety, those are your Klonopin, your Ativan. And what's the one medication I told you we normally give people coming off of alcohol because of the half-life is long? That is Librium. Antipsychotics for their thought disorders, if they're having hallucinations, you can give them a typical or atypical, and that would be typical would be your Abilify, your Zyrtec, Risperdal, Zyprexa. Atypical would be your Prolixin and Haldol. Okay, do you guys remember all of those? Let me go to my next slide. You want to talk to the patient about recovery skills, and this is your AA support groups. I've seen a lot of success when people go into AA, and when you talk to our guest speaker or when she speaks with you in a collaborative talk, she'll tell you how AA has saved her life. And one of your tickets to class is going to be 12 steps of AA, and be ready to discuss those. Okay. And a lot of patients that they will relapse when they say they're too hungry, too tired, too lonely. It's really important that they have a supportive network around them. Okay. Well, they'll relapse hungry, angry, lonely, and tired. And those are signs of relapse. So when speaking about relapse prevention, you want to ask them, who is the support group? What do they do to support so they don't relapse? Okay. When they're having secret thoughts, and you might hear this in AA, the secret of thought, the more secret the thought, the more sick the person. Okay. So it's important that they are honest. Okay. Treatment modalities, again, medical model, you teach them about the disease. Very, very, very important that they comply with treatment. And dual diagnosis treatment is extremely important. Again, in the inpatient setting, you will see a lot of people here at the PUF that are dually diagnosed, and we have to treat both modalities. So maybe they have schizophrenia, so the atypical antipsychotics, and we want to speak about recovery as well. And one of the main reasons that I have you in going to the meeting, so you can make that recommendation. You can tell a patient, have you ever thought about going to an AA meeting? And they might put that back on you and say, have you gone to one? And you can say, yes, because when I was in school, we were mandated to go to one. And I hope that when you go to these meetings, you keep an open mind, okay? And you can use what you've learned in these meetings to help the patients that you're caring for, okay? Some medications that are given to help with abstinence. And abstinence, it means not using. The first one is Antabuse, okay? And what Antabuse does is that it prevents the breakdown of alcohol, so you become extremely sick, okay? You have to make sure that you have a good liver, so before this medication is given, whoever orders it will do a CMP looking at your AST and ALT, okay? And so let's say that's fine. You're given this medication and you drink alcohol, you become violently sick, okay? The bad thing about this medication, if the patient wants to drink, they can stop taking the pill. I think the half-life is about 2 days, okay? But I've seen this medication work. Next one is naltrexone, and this decreases the cravings. It has a euphoric effect of engaging in the addictive behavior. So what happens, it calms everything down. And naltrexone, in my opinion, probably works about 50% of the time. But what really works is when somebody goes to AA, they're open to learning, and they surround themselves with sober people. It's like being a diabetic. You don't want to be a diabetic and, work in a candy store. If you're an alcoholic, you don't want to hang out at a bar. Okay. Antidepressants, they can help stabilize the mood. So again, you have your SSRIs, you have your novel antidepressants, okay? And it's really important to bring the anxiety down, because if your anxiety is down, you might have less cravings for wanting to use any drugs. Okay. And I already touched base on this as far as detox medications here for heroin. That would be your methadone. And methadone normally comes in either a pill or a liquid. At these methadone clinics, and the methadone clinics are normally open in the morning from like 5 a.m. to 8 a.m. And the reason they're open early in the morning is so patients, when they wake up, they can go right and get their dose of methadone and then go to work or do whatever. If it's open too later in the day, they might already slip and use. Methadone liquid comes in, it tastes like Tang, it's orange, and it comes in a liquid. And the reason it comes in a liquid, so you walk up to the counter, they give you your cup, you drink it, and you go on your way. There's less mode for cheeking. And what cheeking is when somebody takes a medication and they don't swallow it, they spit it out. So it's more with compliance. Okay. Any questions? Okay. So this is a lot to learn. This is your third lecture because we've already gone over the intro. We've done legalities, and now you have substance abuse. So what I would do is I would keep on track. I would continue to study, make sure you do your chapter reviews, and I look forward to continued education. So let me stop my slide. Have a great day.